to Rebuilding Lives, Improving Care in HIV. I'm Tabitha Washington with DKB Med. Our faculty today is Dr. Tararit Sambunwit, Associate Division Director with the University of South Florida, Rossani College of Medicine. Here are Dr. Sambunwit's disclosures. This program has been supported by an independent educational grant from Gilead Sciences Incorporated. All activity content and materials have been developed solely by the planning committee members and faculty presenters. Here are our learning objectives. Describe disparities in use of HIV prevention among people with high exposure to HIV, particularly formerly incarcerated individuals. Evaluate benefits and tenets of practicing with cultural humility. Define eligibility and contraindications for PrEP. Identify regimens that are suitable for rapid initiation of ART. In addition to working with our faculty, we've had the opportunity to partner with an amazing organization in South Florida. And now let me turn it over to a team member from Chainless Change.
Thanks, Tabitha. Hi, my name is Rokaya Spencer, and I am a peer support specialist at Chainless Change. We are a community organization that focuses on people that have been negatively impacted by the criminal legal system. We know that people with criminal arrest records have less access to basic resources that they need to live healthy and successful lives. These are especially true for people with histories of trauma, substance use, and mental health conditions. That's why we're so excited to partner with this great initiative. The overall goal of the project is to connect justice-impacted communities with HIV testing and STI testing, knowledge, and treatment to promote health equity. Our team of peer support specialists that work with this community have also been trained in HIV and STI prevention, and we're excited to be able to refer our members to you for their continued care. Back to you, Tabitha.
Thank you, Rakaya. And now we'll move on to our pretest. You'll see these questions pop up on your screen. Please take time to provide your answers. Question 1. Which statement best describes the rate of HIV among the nation's incarcerated population compared with the general population? A, similar to general population. B, double that of general population. C, triple that of general population. Or D, quadruple that of general population. Question 2. Which is a feature of cultural humility and not of cultural competency? A, critical self-reflection. B, maintaining self-awareness. C, working collaboratively. D, knowing values of different cultures. Question 3. Which of the following is a contraindication to PrEP? A, hepatitis B infection. B, injection drug use. C, pregnancy. D, reactive HIV test. E, use of gender-affirming hormones. Question 4. Which regimen can be offered to people with no previous use of cabotegravir PrEP who are newly diagnosed with HIV even before results of baseline testing are available? A, bictegravir TAF FTC. B, lamivudine dolutegravir. C, abacavir lamivudine dolutegravir. D, TAF intracytidine rilpivirine. We'll revisit these questions at the end of our program.
Thank you so much for having me. Let's imagine that you take care of a patient who just came out of correctional facility or justice system, and you don't know where to send them and how to help them. Let's examine the disparity of HIV prevention first, especially among people who recently been incarcerated, People in this environment face unique challenges that make it so crucial for us to tailor prevention strategies for these disproportionately affected by the epidemic. Before, let's understand the landscape for HIV in the US. In 2022, there are almost 32,000 estimated new HIV infections around the country. Among these, 2/3 of them happen among gay, bisexual, and men who have sex with men, and almost 10% that affect people who inject drugs. Nearly half of these infections happen in the South. That is highlighting the regional disparity for HIV prevalence and the need for target intervention. And when you look closer, even though there has been decline in although there has been decline in overall infection, in certain racial and ethnic groups have seen an increase, particularly among Black and Latino population, as you see in this graphic here. Let's look in Florida. Florida is one of the highest rate of HIV diagnosis in the nation. If you see that around the nation, HIV diagnosis rate is 13.3 per 100,000 population, and in Florida is 22.3. This further emphasizes the need of robust prevention and care initiative in this Sunshine State. Before understand more of disparity and equity of HIV prevention, I'd like to introduce the idea of PrEP to need ratio. PrEP is one of the pillars to end HIV as epidemic of prevention. PrEP is pre-exposure prophylaxis, and that is to use antiretroviral medication to prevent HIV before you get it. The PrEP to need ratio is an essential tool to evaluate the equity of PrEP use in the US. It's compared the number of people on PrEP to the number of new HIV diagnoses, showing how well PrEP uptake matches prevention needs. As you look at the number, if the lower PrEP to need ratio, it shows more unmet prevention needs, and also especially under priority communities. Although the overall rate of people who live with HIV in prison has decreased over time, as you see in this graphic, the rate of HIV in prison population is still triple that of general population. This indicates persistent disparities in care and prevention within incarcerated settings. Again, this also highlights the need of the better health preventions. Let's look closer to HIV injustice involved population. Especially who have been incarcerated, they face significant higher rate of HIV infection, as you see here, up to 3 times higher than general population. And in Florida, HIV is 7 times more likely among Florida's incarcerated population. And lastly, the even more vulnerable population is among women. Women with incarceration history have HIV rates up to 15 times higher than general population. This is also emphasize the fact that people with HIV and incarceration history are less likely to engage in care. And why is that? The cause of disparity in HIV care for justice involved population involve lower engagement in care, lack of health care, the prior risk factors such as substance use and condomless use, and also transactional sex post-incarceration. This factor highlight the importance of target prevention and re-entry healthcare services. This slide came from Florida cohort survey that showed that people living with HIV with history of incarceration generally experience worse health outcomes. These include lower rates of linkage to care, retention in care, ART adherence, and durable viral suppression. When you look at this data, the only factor that did not have statistically significant retention in care, but everything else, p-value less than 0.05. These findings call specific intervention to support this priority population. And again, as you see, the data we show here is really conveyed to the same message. Moreover, When we create comprehensive plan to end HIV, the Florida survey for comprehensive plan has surveyed among 211 participants that recently has been incarcerated in the past 12 months. 80% report that justice system staff know about their HIV status, and 65% receive medical care within the prison system. However, you can look at here, upon release, over 40% did not receive any HIV-related assistance, stressing the importance of a gap after those people got released to receive care continuity. Despite the need, many formerly incarcerated individuals did not receive essential HIV care or information after release, such as referral to case manager, medical care, and supplies for HIV medications. This gap of care affects retention in care, viral suppression, and more importantly, overall health outcome. Make it so important for us to improve discharge planning and care transition. More frequently, these are the barriers to care, such as no insurance or financial reasons, no transportation to services, do not know where to go for services, or couldn't get away from the reason why they went to the prison to begin with, such as drugs and things like that. Or this population, they really don't have a good social support. They might have trouble to find trustworthy friends to assist them post-release. And lastly, they did not want others to know the HIV status. This is why, because Florida has such HIV criminalization laws. HIV criminalization law exists in 35 states, penalizing people based on their HIV status, enhancing punishment for certain behaviors. These laws, often outdated, contribute to stigma and discourage testing by focusing on punishment rather than prevention. And when you look specifically with the lens to the south, a close look to Florida, Florida is one of the 11 southern states with specific HIV criminalization laws. These penalize behavior like sex work, blood donation, or consensual sex without disclosure. These laws disproportionately impact women, especially Black individuals and sex workers. And it creates legal and economic burden that affect both public health and justice outcomes. And it has such a big economic impact that over the past 25 years, Florida has spent over $15 million on enforcing these laws when it doesn't need to be there. Now, as provider, how we can shift our focus, how can we help this population? The next thing is understand cultural humility, which is the key to build trust, fostering better healthcare relationship with priority populations. Cultural humility involves acknowledging your own biases and approach every encounter with the mindset of openness and respect. So first of all, understand culture. Culture is not just limited to race or ethnicity, but includes gender, sexual orientation, socioeconomic background. Understanding these dimensions is crucial to provide compassionate, status-neutral, person-centered, very important, person-centered in HIV care and treatment. The role of cultural humility in reducing bias and stress is so important because cultural humility can lead to greater self-awareness. It reduces implicit bias. It improves intercultural relationship and mitigate the effect of minority stress. By as provider or healthcare worker can foster positive engagement with patients from different cultural, different type of background. Healthcare providers can improve outcome for this priority population. Stigma also play importance in health outcome. Stigma, particularly for individuals with history of incarceration, can significantly affect the health outcome. Stigmatization can lead social exclusion, worsen mental health, and hamper effort to seek healthcare, particularly among people who live with HIV. And you can look at here, stereotyping is ingrained in our cultural norm, especially towards people who has been involved with justice system. Negative effects on marginalized group may not even be noticed by population or among themselves. Stigma and discrimination affect identifies of marginalized people, how they see themselves and how others see them. Stigma applies to all marginalized groups, but people who have been incarcerated face particularly high stigma and discrimination. And language used describe individual affected by criminal justice system, often derogatory, dehumanizing, stigmatizing, and bias. Justice-involved population often experience multiple intersecting stressors, such as sexual or gender identity minority group, racial or ethnic minority group, lack of steady employment, unstable housing, substance use, or medical, physical, or mental health condition. So for us, healthcare provider, to understand cultural humility and what to ask our clients is using the 5 R's. The first R is reflection. It's to approach every encounter with humility and understanding there is always something to learn for everyone. Ask, what did I learn from each person from that encounter? Respect. Treat everybody with utmost respect and strive to preserve dignity and respect. Ask, did I treat everyone involved in that encounter respectfully? Regard. Hold every person with highest regard while being aware and not allow our own unconscious bias to interfere with those interactions. Ask, did unconscious bias drive this interaction? Relevance. Expect cultural humility to be relevant and apply this practice to every encounter. Ask, how was cultural humility relevant to this interaction? Resiliency. This is so important in this day of age because resilience really embodies the practice of cultural humility to enhance personal resilience and global compassion. And ask, how was my personal resiliency affected by this interaction? To use a 5R really can help you to a lot of times get outside your comfort zone to be better help to this priority population. And by applying cultural humility, healthcare providers can build trust, improve communication, and reduce stigma in clinical settings. This approach can especially important when you work with formerly incarcerated individuals and other priority populations. Unlike cultural competency, which is knowledge-based, cultural humility is a lifelong process that requires continuous self-reflection. And it is a commitment to address personal biases. Cultural humility emphasizes empathy and collaborative over simply knowing about the difference, as you see in this diagram, the intersection there. The SIO model outlines the key aspect of identity that healthcare providers should consider in their interaction. And it's simply explained here. S, sex assigned at birth, understand what they are. Male, female, intersex, difference of sex, because people might have different sex development. I is gender identity, whether or not cisgender, transgender, non-binary, genderqueer, agender, or two-spirited. Many of these are in the spectrum too. It's not one person can just check in one box. E, gender expression, feminine, masculine, androgynous, butch, femme, drag. O, sexual orientation, heterosexual, lesbian, gay, bisexual, queer, asexual, same gender loving, pansexual, demisexual. And again, many of these you can see as spectrum. To talk to your patient or your client, to initiate a discussion about sexual health, the 5P is really helpful. The 5P framework is ask them about partners, practice, past history of STIs, protection and pregnancy plan. This framework helps because it provides a comprehensive approach to discuss sexual health with patients. This conversation is essential to identify the risk factor and provide tailored HIV prevention services to those clients. Now, since we understand the framework and kind of prepare us for do the real medical stuff, is the next one we're gonna talk about HIV testing. Routine HIV testing is a cornerstone of HIV prevention. Knowing status is the first step of HIV treatment cascade. One of the challenges that we face is the lack of awareness of HIV, especially among the young people. As you see in this statistic, nearly 44% of individuals under age 25 live with HIV and they don't know their status. This really underscores the increased testing and education in this age group. How to test HIV? First of all, fourth generation P24 antigen and antibody tests are the gold standard for detect both acute and chronic HIV infection. For those at high risk, regular testing can significantly improve early diagnosis and engage them in care. Rapid HIV testing also provides results within minutes and improve access to care, especially in settings where follow-up is challenging or difficult to access. However, rapid tests may miss recent infection, so confirmatory tests is needed for positive test result. And very importantly, for anyone that you expect acute HIV infection, check fourth generation P24 antigen antibody test might not be enough. We need to check viral load if symptoms of high-risk exposure are present. So who to test? The current CDC guideline for HIV testing recommend anyone aged 13 to 64 to have HIV test at least once. Patients who start tuberculosis treatment need to check for HIV because not only HIV status need to be known is one of the quality measure for TB care, but also HIV positive status or HIV infection will have to modify, we have to modify TB treatment. Any individual that seek treatment for STIs, as we mentioned before, that STI and HIV, they share a common path to how to get it. Anyone with sign or symptom with HIV or with opportunistic infection, anything that can help making diagnosis if needed, if that person have any immunocompromised condition. Lastly, but very importantly, annual screening to individuals who have increased risk to get HIV, such as men who have sex with men or people who inject drugs, annual testing or more frequently based on the risk factor and local epidemiology. Why this is so important for formerly incarcerated individuals? Why we talk about this? Re-entry population faces several barriers to get HIV care. As you see here, they have lack of insurance or inadequate care transition, internalized racism, PTSD, stigma from incarceration, poor mental health and low health literacy, difficult continuing medical treatment, medication, and substance use disorders. Discrimination against these with criminal records limit access to primary care, and this barrier worsen deficits of HIV screening, prevention, and treatment, and it's really threatened our progress toward end of HIV. One way to break down the barrier to help this population is to create a status-neutral approach. A status-neutral approach is to care for the population that integrates both HIV prevention and treatment to ensure that regardless of the status, the patient receives the care that they need. HIV testing, whether positive or negative, should spur action. This approach normalizes care, reduces stigma, and addresses HIV needs across the population. And it's also come down to undetectable equal to untransmittable, or U equal U. Now, we're gonna move to the next session. This session will review eligibility and contraindication for PrEP and identify the regimen that's suitable for rapid initiation of antiretroviral therapy. First of all, antiretroviral or ART can be used for prevention in two ways. Antiretroviral play a dual role in HIV prevention here. The U equal U message emphasizes that people who live with HIV who achieve and maintain an undetectable viral load. In this study that you see here in this slide, use viral load less than 200 copy per ml. And also you can use antiretroviral treatment for PrEP and post-exposure prophylaxis. That there also can be the key prevention strategy to reduce transmission risk. So what is PrEP? PrEP, or pre-exposure prophylaxis, is the use of antiretroviral medication by people without but at high risk for HIV to prevent getting HIV infection. PrEP works because if you take correctly, 99% HIV risk reduction from sex and 74% HIV risk reduction from injecting drugs. But PrEP only prevents HIV. It does not protect against other STIs. PrEP is recommended for individuals at high risk for HIV, including those with history of STIs, inconsistent condom use, a partner living with HIV. It is also appropriate for individuals who involve in high prevalence networks, such as those recently incarcerated and engaged in transactional sex. Very importantly, based on the most recent guidelines, anyone requesting PrEP, regardless of the disclosed status risk, if they request for PrEP, you should provide PrEP or link them to get PrEP. So how to PrEP? There are three main ways to PrEP: by daily oral PrEP, non-daily oral PrEP, or injectable PrEP. For daily oral PrEP, is delivered by two forms: the drug taking every day, daily. There are two forms of medication we can use. Is by tenofovir desoproxil fumarate combined with emtricitabine, and from now on I will call FTDF. And the other form is tenofovir alafenamide in combination pill with emtricitabine, and from now on I will call FTAF. The second option is non-daily oral PrEP, has some other names such as intermittent PrEP, non-daily, event-driven, or off-label PrEP, and some people even call 211 PrEP. 211 or non-daily PrEP, the only drug is being used now is FTDF, that the first dose taken with 2 tablets of FTDF 2 to 24 hours before sex. The second dose is given 24 hours after the first dose with 1 tablet only, and repeat the last tablet 48 hours after the first dose. Injectable PrEP, long-acting cabotegravir, is recommended dosage as PrEP is 1 injection of 600 milligram, followed by the second injection of 600 milligram 1 month later, as you see in this diagram. And then after that, 2 months, and every 2 months afterwards of the same dose of 600 milligram. As you can see here in the first month, when the drug came out, also oral lead-in was also an option, but now it's rarely a practice for convenience and patient preference. Here is a summary of FDA-approved PrEP medication, as you can see here. I just want to highlight here that FTDF can be used for daily PrEP or 211 on demand. It is indicated for all at-risk population, except people who have creatinine clearance less than 60, and common adverse effects are headache, nausea, and abdominal pain. FTAF is approved only for daily PrEP, not 211. And it is only approved for people with male anatomy among cisgender men and transgender women. And it is contraindicated among people with creatinine clearance less than 30 and lack of data among pregnancy, on-demand PrEP, and people who inject drugs. And lastly, long-acting injectable cabotegravir The dose is highlighted here, 1 injection, 600 milligram at day 0, 1 month after, and afterwards every 2 months. The common side effect is injection site reaction. It is indicated for all sexual exposure risk. Again, sexual exposure risk. It doesn't have enough data among pregnancy. You cannot use for on-demand, and also lack of data among people who inject drugs. Now, I'd like to touch on a drug that has been in clinical trial for PrEP. Injectable lenacapavir for PrEP still now is still an investigational PrEP drug. It is given to sub-Q injection every 6 months. The drug is, however, already been approved for treatment in some countries. The data from PrEP use had derived from 2 large phase 3 clinical trials, Purpose 1 and Purpose 2. From these 2 studies, it shown that early positive result with few HIV infection with people who are on lenacapavir. Purpose 1 includes cisgender women in South Africa and Uganda. And Purpose 2 involves men who have sex with men and transgender population across multiple countries. There are other Purpose studies that's still on clinical trial that are studied in different populations. This slide is very important. As you know that PrEP is easy to do, but you also need to understand when it is contraindicated. The main thing is when the person already have HIV, because PrEP agent would not meet the need of complete HIV treatment regimen. So HIV status must be confirmed with HIV antigen antibody test before you prescribe PrEP to the patient. And if you suspect any possible HIV infection, especially when the signs or symptoms of acute retroviral syndrome or recent high-risk exposure, having HIV antigen antibody test might not be enough. You have to check HIV RNA PCR. The next contraindication is not very common, but you can see that if the person is very small, when their body weight less than 30 kilograms is contraindicated. The rest are basically renal function, that if you're going to use tenofovir-based regimen, renal function will limit them, especially when you would like to use FTDF, creatinine has to be more than 60, and when you use FTAF, creatinine creatinine has to be more than 30. PrEP may be used by people who are pregnant, breastfeeding, using injection drugs, and living with hepatitis B. So these are not contraindicated, and you need to keep in mind as well. Same-day PrEP initiation. Same-day PrEP initiation involves conducting point-of-care HIV testing, pregnancy testing, and culturing lab, especially renal function. Immediate PrEP initiation followed by scheduled follow-up actually can really help us to reduce HIV transmission, especially among individuals who are at risk. In the next 2 slides, I'd like to highlight on the tests that needed by the guideline among people who use PrEP. This rationale divided in 2 groups. One is oral PrEP, which we use tenofovir-based regimen, either FTDF or FTAF, and the other one is injectable long-acting cabotegravir. Among people who use tenofovir-based regimen, the baseline testing, including HIV test, renal function, STI testing. Keep in mind that tenofovir and emtricitabine had activity against hepatitis B. Therefore, it is very important to know the hepatitis B status before you start. It is not contraindicated among those populations, but you need to know so that you can do informed decision with the patient and be aware, because hepatitis B can flare after PrEP is stopped. And the next test is hepatitis C, that we also check as a baseline among increased risk population, especially among men who have sex with men or people who inject drugs. And lastly, if you decide to use FTAF, lipid panel need to be checked at baseline and also every year. In terms of testing, I just want to break down that every 3 months, we screen for STIs and syphilis, gonorrhea, chlamydia, it is recommended among increased risk group. And for every 6 months, we add more tests among people with not as high risk to get STI. Those are everybody who on PrEP that at 6 months now, they should have been tested for STI screening. And also people who have increased risk of renal insufficiency, especially when they're older than 50 or when baseline creatinine less than 90 at PrEP initiation. And then annually, you check renal function in those that did not meet the previous group criteria that need to be checked every 6 months. And then we check all STIs, hepatitis C among the high-risk group, and also lipid panel to be repeated here when the person is on FTAF. More importantly, every single visit, we check for HIV so that we don't leave the patient on incomplete regimen for treatment of HIV. Now, as you see, like in the previous slide, the test is really tied into medical visit when the patient comes for follow-ups. The same thing as person who on injectable cabotegravir for PrEP. As you can see here, we tie with medical visit. So again, HIV testing to be done in every visit. And in person who on injectable cabotegravir, antigen antibody is not enough. You need HIV RNA testing. And then the next group will be syphilis and gonorrhea testing, and lastly, chlamydia testing. I'm going to explain here to make it simple. So again, HIV RNA test to be done every single visit when they come for injection. For syphilis and gonorrhea, to check every other visit, or in other words, is every 4 months among people who are increased risk to get syphilis and gonorrhea. And this include MSM and transgender women, and also true for chlamydia. And then only syphilis and gonorrhea. Some people are not as of high risk. They can be checked syphilis and gonorrhea every 6 months. These include sexually active men and women. And then chlamydia is only need to be checked annually among heterosexual men and women. But again, for men who have sex with men and transgender women, it should be done every other visit already. Keep in mind, not in the guideline, that hepatitis B and C serology are not there. Doesn't mean you don't have to test them. Assess the risk of those patients. If they're at risk to have hepatitis B and hepatitis C, you should screen them as often as the patient needs. Now, since we already talked about the tests that are indicated for people who are on PrEP, now these labs are not routinely recommended for PrEP. Those are complete blood counts, urinalysis, liver enzyme, and DEXA scan. We talk now how to PrEP, and now we also need to understand PrEP uptake is not high enough. That's what we want, and these are the barriers. Based on the literature, there are 3 main groups of the reason why the person doesn't get PrEP. Could be from the patient or the individuals, the providers, and also social constructs. Among the individuals, could be the knowledge gap, the HIV risk perception, the medical mistrust, financial concern, other competing priorities, or concern of confidentiality, or they might have medical indication, which is rare. And then when you talk about us, providers, we might have knowledge gap. We might heard about PrEP, but we don't know what it is, and we're not comfortable to prescribe them. And what is the comfort to provide sexual health service? And also purview paradox. What is purview paradox? Purview paradox is the sense of part of both HIV specialists and primary care clinicians that PrEP does not fall within either purview. HIV specialists are experienced using PrEP medication for HIV treatment, but may not tend to see HIV seronegative people, while primary care clinician may see seronegative people, but less experienced using antiretrovirals. Doctors also have competing priorities. Yeah, so can be very busy to have this conversation with our client, the willingness to prescribe PrEP. And actually, we have seen this quite a bit, that providers afraid to prescribe PrEP because they know that PrEP only prevent HIV but not STIs. And that's perception. Giving PrEP to those clients might encourage them to have condomless sex, therefore increased risk of STI, which is not true. The literature had shown that patients who are on PrEP, they are in the system and they constantly hear the prevention message and also getting tests regularly. They tend to have less STI compared to the same population with the same risk group, but without PrEP. Also, willing reimbursement concern might be the issue, and also concern about patient risk, especially around side effect of medication. Lastly, social construct. Attitude around PrEP like phobia, sexism, racism, HIV-related stigma, lack of healthcare access, the cost or payer source or insurance that might be the issues. With that, let's see how we can help our patients pay. PrEP for All, AVAC, and HIV-MA, these are the advocacy group that support the decision to stop the new enrollment of Ready Set PrEP program. Ready Set PrEP program is part of the third pillar for ending HIV as epidemic. Ready Set PrEP was implemented to help healthcare providers to navigate the clients to have access to PrEP. But this resource was way fewer underutilized. Actually, there are less than 10,000 people enrolled in Ready Set PrEP. And that's why the advocate proposed redirecting the funds from Ready Set PrEP to more comprehensive national PrEP program that cover all PrEP costs, help to leverage affordable generics medication, and also support community-driven initiative. Most insurance plans now, actually, including state Medicaid program, cover PrEP, even though some circumstances might need prior authorization. If you practice in Florida, please know that the Florida health clinics, especially sexual health clinic, they provide same-day PrEP. Even though sometimes they don't have provider on site, they might also be able to do telehealth that have a provider that provide PrEP services around the state. And this website can show you how to find clinics that provide same-day PrEP in Florida. And also, you can use copay assistance program that those manufacturers that make PrEP medication provided for the public. Now we talk about, already talked enough about prevention. And now what if you test your patient and became positive? For individuals who are newly diagnosed for HIV, initiating antiretroviral therapy, now I'm going to call ART. We should initiate ART as soon as possible, and immediate ART uptake will increase engagement in care, and is really expedite viral suppression. It reduces both morbidity and HIV transmission. So not only you take care of the person, but you also take care of the community. This is a hallmark study that was published in 2015. The INCISE trial showed that early ART initiation, regardless of CD4 count, reduced the risk of serious illness and death, and also prevent some complications like bacterial infection or cancer. Immediate ART initiation also helped to achieve viral suppression faster and prevent complications from HIV infection. If HIV test is reactive, how do you do for immediate ART initiation? So first of all, ART is recommended for everybody to reduce morbidity, mortality, and prevent transmission. So that's the why. But understanding too that some people do not engage in care. So even though they get diagnosed for HIV, there might be some gap between the time of diagnosis and until they get ART prescribed, and actually that can be missed opportunity. ART should be initiated immediately or as soon as possible after HIV diagnosis because it increases ART uptake, increased engagement in care, and it accelerates time of viral suppression. The goal of treatment, we start ART to, again, it's redundant from the previous slide, but it is important. So we say again, to achieve viral suppression as soon as possible. When your viral load is suppressed, you will help to restore and preserve immune function. It reduces HIV-associated morbidity. And also with that, you can prolong duration and quality of life. And for epidemiologic standpoint, it's undetectable, is equal to untransmissible. It's also benefit to prevent HIV transmission. And why same-day ART or rapid ART start is so important? Look at this slide. Time of ART initiation. You can see that the rapid program, which offers same-day ART initiation, have been shown to significantly improve viral suppression rates compared to standard of care, as you can see in this slide, that initiating ART on the day of diagnosis, patient more likely to engage and in long-term treatment, and also viral suppression achieved much faster. So what happened when you test your patient and HIV test is reactive? We use ART and we start ART immediately after diagnosis because we know that it will improve the outcome. Early ART improve viral suppression rate, but if you're not sure or you're not comfortable, it is important to refer to HIV specialists by provide a warm handoff. In order to do that, it is important to, in your community, identify your HIV referral pathway in advance. The next one, we would like to touch on what it said in the guideline. The US DHHS guideline for initial therapy. So we divide into two groups. This among the preferred agents. So the first group among people who do not have history of using long-acting cabotegravir as PrEP. So one of these regimens listed here are recommended as initial therapy because the cornerstone now that we use more integrase inhibitor-based regimen, in this case, would be either bictegravir or dolutegravir. And bictegravir, FTAF, or dolutegravir plus tenofovir, either TDF or TAF, plus one of those agents, emtricitabine or 3TC. These are two main regimen also can be used at rapid ART initiation. Dolutegravir lamivudine is not recommended for rapid ART initiation because you have to know viral load first. And you also need to know hepatitis B status. It is not recommended when your viral load is super high, like more than 500,000 copies per ml, or you have hepatitis B co-infection that will be contraindicated, and you need to use different regimen. And for people who have history of long-acting cabotegravir to use as PrEP, you have to know integrase inhibitor genotype resistant testing should be performed first, so that before you can use antiretroviral with integrase inhibitor, you need to get that test result. Therefore, in this regimen, to start with, you need to have protease inhibitor-based regimen such as boosted darunavir, either with cobicistat or with ritonavir, plus tenofovir, and either emtricitabine or lamivudine, pending the result of the genotype testing. The baseline evaluation for the labs, what do we test? We want to know the immune status and the disease burden by checking CD4 and viral load. And also we want to know general health status, including complete blood count, chemistry, including glucose, kidney function and liver function, and urinalysis. We also want to know hepatitis A, B, and C status, because not only we can provide immunization, and also we need to know what else needs to be treated. If you plan to use abacavir in your patient, HLA-B5701 also is indicated And very importantly, genotype drug resistant testing need to be done for all patients at baseline. We have come a long way and we cover a lot of material for our learning objectives. I want you to take some of these away. And one is about HIV disparity. By now, you know that formerly incarcerated individuals face barrier for HIV prevention, and HIV rates in this population has been triple that to the general population. Understand cultural humility by addressing bias through self-reflection, build trust, and foster positive intercultural relationship, especially among the priority populations. Understand PrEP. Know that PrEP works. PrEP reduces HIV risk by 99% when you take correctly, and it is recommended for anyone at perceived HIV risk, except those with already HIV, or too small, less than 35 kilo. Antiretroviral therapy, ART. ART is for all. All individuals with HIV should receive treatment regardless of their CD4 or viral status. Immediate ART initiation is so important for newly diagnosed individuals, and the single tablet regimen with bictegravir F-TAF is appropriate for people with no previous exposure to long-acting cabotegravir as PrEP before baseline test results are available. And lastly, this is so important that we don't work alone. Multidisciplinary care is so effective, and effective HIV care requires coordination across healthcare and support services.
And now let's revisit those questions you answered in the beginning. As before, the questions will pop up on your screen. Please take the time to answer the question. Question 1. Which statement best describes the rate of HIV among the nation's incarcerated population compared with the general population? Please answer now. This is how you responded before, and here's how you responded now. Dr. Sabunwit, what is the correct answer?
So the answer of this question is answer C, triple that general population. I just want to remind you about HIV among people in prison. Even though there's far fewer people in prison living with HIV now than in the past, but HIV rate in prison actually tripled that of our US general population.
Question 2. Which is a feature of cultural humility and not of cultural competency? Please take the time to provide your answer. And here is how you answered previously. And here are the results now. And what is the correct answer?
The answer of question 2 is A, critical self-reflection. I just want to reflect back to the slide that you see the difference between cultural competency, which is knowledge-based, and cultural humility, that is required continuous self-reflection. So this is the correct answer.
Question 3, which of the following is a contraindication to PrEP? Please take the time to respond. Here is how you answered previously. And here's how you responded now. Dr. Sabunwit, please give us the correct answer.
For question 3, the answer is reactive HIV test. Just to remind you that antiretroviral component in PrEP medication, they are not sufficient to treat person with HIV. Therefore, person who already have HIV is contraindicated to get PrEP, they need to have full regimen.
Question 4. Which regimen can be offered to people with no previous use of cabotegravir PrEP who are newly diagnosed with HIV, even before results of baseline testing are available? Please provide your answer now. Here is how you responded before. And here is how you responded now. And here is the correct answer.
Question 4. The answer is A, bictegravir F-TAF. And I just want to reflect back to the DHS guideline that you see that US DHS consider initial therapy, that you can see here that with bictegravir F-TAF is a single tablet regimen that is appropriate for rapid start.
Thank you so much, Dr. Sabunwit, for providing the answers to our post-test questions. And now we're going to move into the Q&A segment of our session. You will see below there is a block that you can enter your question. Please take the time to type that in. I will read your question aloud, and Dr. Sabunwit will answer your question. So we have questions coming in. This is great. First question. If someone with HIV had a lapse in treatment, but is now ready to re-engage in treatment, how does that affect choice of treatment?
Yes, absolutely. First of all, it is important to understand why the patient had lapsed in treatment. And then once you understand the barrier, the next step is evaluate the health status. You want to see the stage of HIV where they stand, how much is the CD4 or viral load, or any other comorbid conditions. And very importantly, if you know baseline resistant testing, that also come into the consideration, and also get other resistant testing will be really helpful to exclude certain regimen that you cannot use. And then with all the data and all the reason why the patient lapsed to begin with, then you can come up with the regimen that appropriate for that particular patient. It is very important that this has to be informed decision you discuss with the patient so that patient will feel that they are supported and that it will increase the chance of re-engagement in care.
Thank you for that. Again, if you have a question to submit, you will see on the console where you're watching this video beneath it is a spot to go ahead and enter your question. The second question we have is this: is injectable PrEP preferred for people with adherence issues? What happens if the patient misses an injection?
What a great question. As you know that when you have to care for an individual who not adhere to the regimen, again, that might be a lot of barrier that why they can't. Sometimes they simply have too much going on in life and they just forgot to take the medication. So among those individuals, injectable PrEP is really a good option because it's only, it doesn't need to be taken every single day, but you have to be very careful because the only injectable ART that for PrEP that is available right now is only one drug, and if you miss the dose, and you can create the drug resistance that really exclude those patients to take integrase inhibitor, which is make it very simple because you have one single tablet regimen. So you have to emphasize on adhere on those visits, even if they cannot make it on the day that they have the appointment for the injection. The grace period is about 7 days. And if it's over 7 days, you need to bridge those patients to take oral PrEP.
Thank you for that. Oh, the questions are coming in. This is great. Okay, the third question. How do I bring up the topic of sexual history for a patient who comes to my clinic for another reason?
Well, actually, it can be difficult conversation, as you learn in this program, that in order to be able to have those type of conversation, you need to establish trust and understanding with those individuals. It requires sensitivity, professionalism, and also non-judgmental approach. Active listening is a key. We emphasize on privacy and normalizing conversation as much as possible. And one of the key as well, that when you ask open-end question, you really gain more information from those patients.
Another question, and again, just a reminder, if you have a question that you want to ask, just go ahead and type it into the box that you see below the console, and we'll go ahead and read your question aloud and answer it. The next one is, would providing PrEP for incarcerated persons be considered a violation of PREA-like distributing condoms?
So having prevention, so in each correctional facilities, they have their own medical providers, and they have their own policy, how they are distributing HIV treatment and prevention. When you discuss the treatment option or prevention options for those who just recently been incarcerated, that's going to be more like continuation of risk assessment, so that we're preventing them to get HIV. Prevention of HIV when they are in those facilities actually will help a lot to reduce costs and actually to reduce healthcare disparity when they come out, and when we try to re-engage those clients that come out of those correctional facilities.
Okay, another question. Do I need written consent from the patient to test for HIV?
This is a great question, and actually can be the myth from a lot of providers, because sometimes in your institution might practice a little bit differently. But I just want to make an emphasis here that to get HIV tests in Florida, you do not need written consent, okay? Based on Florida statute, written consent is not required for HIV testing. However, Florida law mandates informed consent to be obtained, but you don't have to have it signed. You can just discuss with the patient who you want to test, and then you documented that this has been discussed with the patient. That would be sufficient, but it has to be documented medical record. In some facility or institution, they might build in the order set that when you order for HIV test, they just check the box like I have discussed and have obtained verbal informed consent from the patient. And if you build into your EMR, that's great. That will reduce the barrier to test those patients.
Here's one. How long does it take to achieve an undetectable viral load with current HIV medications?
Actually, it's very quick, because most of first-line antiretroviral regimen now is including integrase inhibitor. And one of the characteristics of integrase inhibitor is had rapid viral decay, which means after you start treatment with integrase inhibitor in the full regimen, the virus got suppressed very, very quickly. But in general, you should expect within 3 to 6 months, the patient should achieve viral suppression. And it's also depending on how high of the viral load to begin with as well.
Okay, great questions coming in. Our next one, is HIV reportable to the health department?
Yes. And actually, I was one of the training session last week. This was coming up during the session, because as you know that the lab a mandate to report reportable diseases that in the statute that they will send the lab to the health department, even though the lab had already report those positivity of the test, provider also need to report, and those infections including HIV. So for healthcare provider who provided care for the person who have HIV diagnosis had to be reported to the health department. The health department also had a data set that they know that who already been diagnosed in Florida, but sometimes you might come across that the client might be moving to your area and never had positive tests in Florida before, and initially those can be labeled as new case. But then with the collaboration of providers and the health department, they can work together to help the patient to link to care and establish care as needed.
All right, thank you. We're going to go ahead and thank you everyone for submitting their questions. We're going to go ahead and take our last question for this session. And this one is, how do I talk with a patient who is reluctant to start PrEP or HIV treatment?
Yeah, this is a great question. And isn't the question that we come across very often in our practice? Because if you remember in this program, we talk about the barrier of PrEP. One is the individuals with all the barriers that they might not know about PrEP, they might not sure, they have medical mistrust, and also the provider with the knowledge and reluctancy to prescribe medication to prevent HIV, but does not provide a prevention to other STIs. And lastly, with the social construct that really create a barrier, how this population have access to PrEP. And again, we go back to active listening and creating trust. And also during those conversations, allow the patient to empower themselves towards the knowledge that you're giving to them, and refer them to the resources if needed. For example, in your practice setting, you might not have the access to same-day PrEP, for example. Then it is important to work in your community to identify a facility or the partner that could help you to provide a warm handoff to hand those patients so that they can get PrEP. And also, self risk perception can be one of those that can be the barrier that comes from the patient, that what we encounter a lot in our clinical setting, especially around the sexual health clinic, because the patient might say that, oh, I have this just once and this won't happen again. But if you can just send the same message like, hey, STI and HIV, how you get it is really from the same route. If you have this already once and you could have it again, you might as well to protect yourself by taking medication.
Thank you so much, Dr. Sambunwit, for being with us today. Thank you for taking the time to answer the questions. It's been great. I've really enjoyed this session. Thank you, everyone, for taking the time to be with us today. We hope that you've enjoyed the learning session for today. And thank you so much for the questions that you asked. We want to make sure that you complete your evaluation. You will see on the console, there is a button that says claim credit. Make sure that you fill that out so that you will get credit for attending this session. And if you have any questions or for more information, please contact us at info@dkbmed.com. I am Tabitha Washington. I've been fortunate to be your moderator for today. We hope that you will join us in the future for future DKB Med programs. Thank you. Have a great day.